Well, welcome everyone. It's a pleasure to have you come here today to listen on this topic on pediatric autoimmune neurologic disorders. My name is Eoin Flanagan. I'm a professor of neurology here at the Mayo Clinic. I work in the Mayo Clinic Neuroimmunology Laboratory and also in the neurology clinic where I pursue multiple sclerosis and autoimmune neurology and follow patients with these conditions. So today we'll focus in on pediatrics and autoimmune disorders. These are my disclosures, which are not too relevant to the topic here, as we'll focus mostly on diagnosis. So when we think about inflammatory demyelinating diseases of the central nervous system, we can think about multiple different attack types or syndromes. So acute disseminated encephalomyelitis, it's a bit of a complicated term, but basically means inflammation within the brain and the spinal cord that's extensive. The second one is transverse myelitis, or inflammation within the spinal cord. The third is optic neuritis, or inflammation within the optic nerve. And then we have some other types of encephalitis or brain inflammation, brainstem or cerebellar type syndromes. And then we can have combinations. Sometimes if we have a combination of transverse myelitis and optic neuritis, we use the term neuromyelitis optica or neuromyelitis optica spectrum disorder. So these are all terminologies that we use to describe different attack types, particularly initially before we have some of the testing back and we have a defined diagnosis, but later sometimes we can refine to specific diagnoses, and I'll show that through many of the next cases that we show. So the first case here, this is a 15-year-old female, and this person presented with subacute double vision and imbalance. Their neurologic examination showed a right-sided internuclear ophthalmoplegia, so some eye movement abnormalities. And what you'll see here on the MRI is that there's evidence of multifocal T2 hyperintensities within the white matter. Some of these show enhancement on the postgadolinium images, and this imaging appearance with these periventricular lesions is pretty typical of multiple sclerosis, and this high disease burden is pretty typical actually in pediatrics where they often have a lot of inflammatory lesions. The patient's spinal fluid showed some inflammation with 22 white blood cells, and the patient was positive for kappa-free light chains and oligoclonal bands. So the diagnosis here was relapsing remitting multiple sclerosis, and the patient was placed on a B-cell depleting agent called ocrelizumab. In this case, we were now able to move from an initial brainstem syndrome to a defined diagnosis, being multiple sclerosis here. And then what we'll talk about over the next many slides is a few other demyelinating diseases that are associated with antibodies. The first being aquaporin 4 antibody positive neuromyelitis optica spectrum disorder, and the second being MOG antibody associated disorder or disease. So when we try to diagnose MS, we have 5 major steps. The first is looking at the clinical features. We generally see subacute onset of symptoms over days to a few weeks, and that can be numbness in the lower extremities or weakness. People can have vision loss or pain with eye movements. You can have double vision or imbalance like we saw earlier. And then some other patients will have more of a progressive course, usually in the form of a myelopathy. But that's usually older people. We don't see that in children as much in that situation. The neurologic examination can sometimes be normal in the setting of multiple sclerosis. So a patient may tell you they're numb from their waist down, but your examination, you may not find too much findings, or you may have characteristic features like the last case with an internuclear ophthalmoplegia. The imaging is really important, and the MRI of the brain, cervical and thoracic spine, and then sometimes we'll take an image of the back of the eye called an optical coherence tomography test, or OCT. The spinal fluid can often show oligoclonal bands or kappa-free light chains in about 85%, and usually the white blood cell count is between 0 and 50. And indeed, in the latest diagnostic criteria just published earlier this year, they now allow patients who are asymptomatic but who have multiple MRI changes suggestive of multiple sclerosis to achieve a multiple sclerosis diagnosis. So lots of changes in the diagnostic criteria have led to us to be able to identify patients who have MS who are maybe detected when they're asymptomatic. They might have an MRI during a car accident or otherwise. It's important to evaluate for mimics, and we'll talk about some of those over the next many slides. In terms of the imaging that we talked about, we can see with MS these typical periventricular T2 hyperintensities that we can see here. We can see these Dawson's fingers of MS lesions on the sagittal images, and then sometimes we'll see these ovoid periventricular lesions. When we do the postgadolinium images, we can see multifocal enhancing lesions. And then here we can see juxtacortical or next to the cortex lesions or infratentorial. In the brainstem here, we can see a T2 hyperintensity. And then sometimes we'll see these chronic T1 hypointensities within the white matter. In the spinal cord, we tend to see shorter lesions extending 1 or 2 vertebral segments like we see here with some enhancement. And on the axial images, they tend to be in the periphery of the cord here in the dorsal columns with enhancement. We now have a new profile. The kappa-free light chains were recently incorporated into the latest diagnostic criteria and are another way of measuring for intrathecal synthesis of immunoglobulins, similar to oligoclonal bands. And they basically perform almost identically to oligoclonal bands, but they have some technical benefits in terms of they can be resulted faster and they're more standardized. So we've been using the kappa-free light chains in our practice now, and the latest diagnostic criteria allow you to use these to make a diagnosis of MS. In terms of disease-modifying treatments for MS, we have a whole range of different FDA-approved treatments, and many of this literature is extrapolated from adult literature, but we really have a wide range of treatments, and the treatments are generally categorized as either high efficacy or strong medications or lower efficacy. And in general, the research has suggested that using a higher efficacy agent earlier seems to be more beneficial. A second case here, this was a 6-year-old female, and this patient presented with double vision, some imbalance and confusion after a recent upper respiratory tract infection. On examination, it was noted that she was encephalopathic, she had ataxia, and had some left-sided weakness. And what you'll see here in the imaging is there was a T2 hyperintensity within the middle cerebellar peduncle on the right, and then we saw some deep grey matter lesions within the thalamus, the basal ganglia, and the internal capsule. The spinal fluid showed elevated white blood cell counts, but this time there was no evidence of any oligoclonal bands. So the initial diagnosis was acute disseminated encephalomyelitis, or ADEM, and the patient was treated with IV steroids and an oral taper. The patient later developed recurrent episodes of ADEM and also had an episode of bilateral optic neuritis, and that led to the MOG antibodies being tested, and these came back high positive. So the patient was then diagnosed with MOG antibody-associated disease, or MOGAD. The patient was placed on maintenance immunoglobulin treatment, 1 gram per kilogram every 4 weeks, and that seemed to work well for attack prevention. Going to move on to the next case. This was a 14-year-old male, and this patient developed pain in the right eye and then pain with eye movements on that side, and also that was followed a few days later by some vision loss in the right eye. And the vision got so severe to the point they were almost blind in the right eye. And when the physician looked in the back of the eye, there was evidence of optic disc edema or swelling, and there was something called a right relative afferent pupillary defect, highlighting some impaired conduction in the right optic nerve. The MRI of the orbits is shown here, and you can see evidence of enhancement in the anterior optic nerve. And here you can see enhancement on the right optic nerve when compared to the normal, more gray left side. The white here in the optic nerve is evidence of inflammation. This patient was tested for MOG antibodies and strongly positive. So although the initial diagnosis was optic neuritis, when the MOG antibody came back positive, we were able to transition the diagnosis to MOG antibody-associated disease. In the interim, while waiting for the results to come back, the patient was treated with IV steroids and a slow oral taper and recovered fully their vision. And in this situation, the patient was not placed on any maintenance immunotherapy because some patients can have a monophasic course and never have a future relapse. So we often wait until the second attack before initiating treatment. So MOGAD is a relatively new disease, and this just highlights some of the features of that. It's often preceded by an infection or very occasionally by a vaccination. And children are particularly predisposed. They account for about 25% of all of MOGAD, and it accounts for about 1/3 of pediatric CNS demyelinating disease. So it's really something you want to consider if you're seeing a child with a demyelinating presentation. The female to male ratio is a little bit less than we see with MS or neuromyelitis optica, in that it's 1.5 to 1, and there doesn't seem to be any at-risk ethnicities that we know of so far. There may be a slight winter seasonal predilection to attacks, but attacks can occur any time of the year. and the prevalence seems to be about 4 per 100,000, but probably that's an underestimate, and as more patients are tested, we'll start to identify this more. And just to show here the differences by age in children, the two main manifestations are similar to the cases that I showed, with optic neuritis and then acute disseminated encephalomyelitis. And then in adults, myelitis becomes a little bit more common, so inflammation in the spinal cord, and then optic neuritis really dominates the picture in adults. We can have other attack types. There's something called cerebral cortical encephalitis, which is found in about 7% of MOGAD patients. And these patients can present with headache, seizures, confusion, stroke-like episodes, and fever. And NMDA receptor antibodies can sometimes coexist in these patients. And here what you'll see on the MRI is you'll see this T2 hyperintensity within the cerebral grey matter. And then you can see there's no evidence of any white matter lesions, which sometimes can lead to misdiagnosis, as people think of white matter lesions when they think about demyelinating disease, but you can have demyelination within the cortical grey matter. And you can see the cortex was swollen and bright when compared to the other side here. There was also some evidence of leptomeningeal enhancement, and this patient actually had a brain biopsy because it was the initial diagnosis of MOG was not certain, and there was evidence of demyelination within the cortex consistent with the demyelinating condition. Some patients with MOGAD can have life-threatening attacks. We've seen about 2 to 3% that can require respiratory support with mechanical ventilation. We can also see increased intracranial pressure in some of these patients with MOGAD attacks. And what you'll see here is some examples of diffuse cerebral edema here in a child with early herniation occurring here in this patient, so these life-threatening episodes. And sometimes interleukin-6 receptor blocking therapy with tocilizumab can be life-saving, but other times patients may need hemicraniectomy, or you may need to remove the skull temporarily as a life-saving measure for some of these patients. So just remember that particularly in pediatrics, they can have very severe attacks, and these patients can rapidly deteriorate, and you really want to involve your ICU team, your neurologists, and your neurosurgeons to help manage these patients, and they may need life-saving measures like diuretics or high percentage saline, etc. In terms of other involvement, sometimes we can see a meningeal involvement, so we can have more of a meningoencephalitis in MOGAD, and then we can sometimes see some cranial nerve involvement or spread of the inflammation, probably from the parenchyma into the cranial nerves, or sometimes from the lower spinal cord into the cauda equina nerve roots. You have to be a little bit cautious. We'll talk about the MOG antibody. It's a little bit sticky, so some patients can have false positives. So be careful if you see papers published in the literature where they talk about MOG antibodies and very unusual phenotypes, because it is a little bit of a sticky antibody. And this is just showing here how we do the antibody test. So here you can see we have human embryonic kidney cells with the receptor of interest, which is MOG, placed on the surface. And then we add the patient's serum. And then we add a secondary antibody with an immunofluorescent tag. And then we can look either via microscopy or flow cytometry to look at the readout. And if this is positive, we'll get a positive readout. And then we'll do titrations to see the strength of positivity. And the higher titers tend to be more reliable. We did a study at the Mayo Clinic before showing that the high titers of 1 in 1,000 or greater very rarely have false positives. But as I said, the MOG antibody is sticky, particularly at those low levels, where we can see up to half of those cases can be false positive results. So you got to be a little bit careful. This was borne out when we compared our MOG assay across different regions, and what you'll see here is that the negatives tend to be negative in all the labs, and the high positives tend to be high positive in all the labs, but the low positives are variable across different centers, just highlighting some challenges with the low positive results. And then there are different types of assay, the fixed and live cell-based assay. Really, the live cell-based assay has some advantages, particularly in terms of sensitivity. So you may miss some cases if you test with the fixed only. So if you do test with the fixed only, you're suspicious for MOGAD and it's negative, you want to consider sending it for a live cell-based assay. These are the latest diagnostic criteria that were published in 2023. And again, it focuses in on this classical presentation like we showed in some of the cases or some of the examples after that. This could be optic neuritis, myelitis, ADEM, other brain or brainstem or cerebellar involvement, or this cerebral cortical encephalitis. So once you have that clinical syndrome, then you need to have a positive MOG antibody test. And if your positive test is clear positive, then you may not need anything additional. But if you're low positive or positive as spinal fluid only, you'll need some additional radiological or clinical features. And then the final step, like we always do in medicine, is exclusion of an alternative diagnosis, including multiple sclerosis. So you've got to be a little bit careful with the sticky MOG antibody. So overall, we can summarize the criteria as a core demyelinating event, a positive MOG antibody, and excluding a better diagnosis. We talked a little bit earlier about the monophasic versus relapsing course. Some patients will only have one episode, and we don't want to expose them to lifelong or long-term immunotherapy if they're destined never to have another attack. On the other hand, when patients do develop relapses, we tend to jump in with treatment. The attacks tend to cluster early on and then tend to reduce a little bit over time. So even in those patients who do relapse, those relapses tend to occur early after onset, and then it's a little bit less later on. In terms of treatment, we generally use high-dose IV steroids for MOG, and it tends to be very steroid responsive, so most patients will get a good improvement from the steroids. But in refractory or severe cases, you might want to consider plasma exchange, or we talked about some of those neurosurgical procedures or IL-6 blockers for those really fulminant cases. Right now, we don't have any FDA-approved treatments, but clinical trials are ongoing, and we're hoping to have more treatments down the line. We sometimes use off-label IVIG or tocilizumab, which is an IL-6 blocker, as our treatment for MOGAD, preventing future attacks. So next case, this was a 16-year-old female, and she presented initially with nausea and vomiting, and then developed subacute weakness, numbness, and neurogenic bladder to the point where she was no longer able to walk, required a wheelchair to get around, and required a urinary catheter. And the MRI showed evidence of a T2 hyperintensity within the spinal cord that was what we call longitudinally extensive, meaning it extends beyond 3 vertebral segments, and there was some spread to the dorsal brainstem, which is what we call the area postrema, or the vomiting center within the brain, which may explain some of these symptoms. The CSF showed some inflammation, but no oligoclonal bands, and this patient was tested for aquaporin 4 antibodies and positive. So the diagnosis here was aquaporin 4 antibody positive neuromyelitis optica spectrum disorder. The patient was treated with IV steroids and plasma exchange, and then placed on IV maintenance rituximab at that time. So what about the cardinal features of this condition? Most patients with this condition, unlike MOGAD, will have future relapses, so we generally treat after the first attack with this condition. And patients can have optic nerve inflammation or optic neuritis, similar to MOGAD, which can also have optic neuritis, and then we can have inflammation within the spinal cord with these long lesions like we saw in the last case, and then they can have involvement of this area postrema syndrome, which is the vomiting center of the brain, and sometimes that leads to patients initially presenting to a gastroenterologist with vomiting, nausea, hiccups, and then eventually when they develop neurological symptoms, the neurologist becomes involved. So you need to watch out for that involvement of the vomiting center of the brain, because it can cause some confusion. The aquaporin 4 antibody assay has been refined over the years, and now testing in blood is optimal, and really all we need is blood. The CSF doesn't seem to add much. The older generation assays had some challenges with false positives, but the aquaporin 4 antibody assay is much more reliable than the MOG assay, and the specificity is very high, 99.8%. So rarely see false positives with our cell-based assay, and this is just an example of the assay we use here at Mayo Clinic, showing a positive result in green here with lots of binding to the cells with aquaporin 4, which is above the binding to the background cells. In terms of acute attack treatment for the neuromyelitis optica spectrum disorder, we tend to use IV steroids, similar to what we use in MOG, but these patients often require plasma exchange. So we have a very low threshold to use plasma exchange, because these patients can have less recovery and we have to treat them a bit more aggressively. IVIG is sometimes used as an add-on treatment, but really steroids and plasma exchange is the mainstay for acute treatment, and we should generally probably be using both in almost all of our patients when they attack. This was a study by Dr. Weinschenker showing plasma exchange being beneficial in the setting of CNS inflammatory disease refractory to steroids. And this was before the aquaporin 4 antibodies were available, but there was probably some patients who were aquaporin 4 positive in this study. There are multiple proven treatments now for aquaporin 4 positive NMOSD. This is a list of all of the different treatments. These target different aspects of the immune system. Some of them target complement, which is a factor that can NMO seems to be quite involved with, and one of the risk factors of that, of complement inhibition, is meningococcal infection. So you've got to be a little bit careful in your patients with NMO. They're at risk of meningococcal disease. There are other treatments that target both CD19 and CD20, which are B-cell targeted treatments, and some of them also target plasmablasts. And then we have interleukin-6 blockers, which also seem to work well in this condition. Older generation medications like mycophenolate and azathioprine are used less frequently, as we now have class 1 evidence for many of these other treatments, but rituximab is still a good option and affordable and available around the world. Okay, so next case, a 16-year-old female. This patient developed subacute psychosis, was initially admitted to the psychiatry unit, then developed a seizure and had catatonia. The neurologists were called and some investigations were undertaken. An MRI of the head was normal, but CSF showed some inflammation with 20 white cells. And what I'll show here is on the EEG, there was some evidence of this delta brush pattern, which is some slowing with superimposed fast activity. And then on the sample that was sent in, what we saw in our tissue-based assay was we saw binding to the hippocampus and to the granular layer. And then we were able to confirm with our cell-based assay that it was positive for NMDA receptor antibodies. The cells with NMDA in the surface lit up positive, while the other cells by the arrowheads here were negative. So this was a diagnosis of anti-NMDA receptor encephalitis, and this patient was treated with IV steroids. IVIG actually had plasma exchange also, and then rituximab. And this tends to take a while to get better. So this patient was hospitalized for 2 months and then improved to normal over the course of 10 months. But these patients can, even after a prolonged coma, make a great recovery. So you want to treat these aggressively and not give up on them, because even if they're in a coma for a long time, they can still get better. The antibody to the NMDA receptor is an antibody to a cell surface agent, and this diagram here shows some examples of how the antibodies work. So what you can see is the antibody might bind to the receptor, and that leads to internalization. You may get binding to the receptor that leads to dysfunction of the receptor. You may get recruitment of other immune cells, antibody-dependent cellular cytotoxicity, or you may get complement activation. And these are all mechanisms on which these antibodies can work. And because they bind to a cell surface receptor, they can be directly pathogenic. And therefore treating the antibody by either getting rid of the antibody with plasma exchange, neutralizing with IVIG, or preventing its production with B-cell targeted treatments can be helpful, or if complement is involved, inhibiting complement can also help. These patients tend to have a lower risk of cancer than patients who have antibodies to intracellular targets, but teratoma can occur with the NMDA receptor antibodies, and they tend to respond well to treatment and have a good prognosis. So what are the most common antibodies detected in children? Well, we've done this study and we found that NMDA receptor antibodies were the most common in serum. We didn't yet have CSF MOG antibody testing available, so NMDA again dominated the picture in CSF. So these are the two main antibody associated conditions that you need to look for, and some patients will actually have a mixture of both, and they can have overlapping phenotypes, and this has been shown in our lab and also in a lab in Barcelona. So highlighting that your two main antibodies you want to be worried about is the NMDA and MOG antibodies, and these are available on our Pediatric CNS panels, so both of these will be tested on both. And oftentimes it's good if you're highly suspicious for an autoimmune condition to test both serum and CSF. There are some other syndromes that we can see in children. Opsoclonus myoclonus can be seen, sometimes in the setting of a neuroblastoma and with ANA1 or anti-Hu antibodies. And some of these patients can go on to develop GI dysmotility. So this is something you want to consider if you see opsoclonus myoclonus. Check if the patient has a neuroblastoma, and if the patient develops GI dysmotility, you want to test for these ANA1 antibodies. Just a final word on autoimmune encephalitis misdiagnosis. We are all aware that these new antibodies have been very helpful for diagnosis, but we also have to be cautious about over-interpreting antibodies. This was a study that we did at Mayo Clinic where we looked and we found a third of patients were misdiagnosed as autoimmune encephalitis when they actually had something else. And some of these other conditions that they had included functional neurologic disorder, psychiatric disease like schizophrenia, or non-encephalopathy, brain fog, polypharmacy, fibromyalgia, etc. And then other patients could have neurodegenerative conditions. They may have neoplasms that were mimicking inflammation, or they may have other genetic conditions like MELAS, which we can see in children, or just epilepsy, which we can also see in children. So you got to think about a broad differential diagnosis when you're evaluating your patient for possible autoimmune encephalitis. This was some examples in that series. You can see here a glioma in the temporal lobe mimicking limbic encephalitis. We also have had some patients who responded to steroids who actually had lymphoma. This was a patient with HIV-associated leukoencephalopathy. This patient here had MELAS with recurrent episodes of encephalopathy that would then improve, and each time they would be hospitalized, they would be given steroids, but the improvement is the natural history of these attacks of MELAS. And then you can see neurodegenerative conditions that we don't tend to see as much in children. The most common reasons for misdiagnosis in this study was overinterpretation of a non-specific antibody. So you got to be cautious with your thyroid antibodies, which are present in up to 20% of the population and are not a good marker of autoimmune encephalitis. GAD65 antibodies at low level are also seen in many diabetic patients and can be seen in those with a predisposition to autoimmunity. And then some of the older generation techniques like Western blot immunoprecipitation are a little bit more challenging and have more false positives. So you got to be careful with low positive serum results in particular. The CSF is a little bit cleaner, but serum can be a challenge. So always have to put your antibody results in context. Sometimes there can be misinterpretation of non-specific or functional symptoms as true neurologic, or other times there can be a reluctance to accept a psychiatric diagnosis and people want to pursue immunotherapy trials. So, in conclusion, MOG and NMDA receptor antibodies are going to be the most common antibody-associated demyelinating diseases in children, but also think about multiple sclerosis, and we talked a little bit about that. Recognize the potential for MOGAD to have fulminant attacks. These patients can deteriorate rapidly, and you want to involve your ICU team, your neurosurgeons and neurologists very closely. Remember that intractable nausea, vomiting, and hiccups can occur in NMOSD related to involvement of the area postrema or vomiting center of the brain. And then recognize some of the pitfalls of these antibody tests and autoimmune encephalitis misdiagnosis, and be cautious with these low positive, less specific serum antibody results. So I'd like to acknowledge this is our neuroimmunology group at the Mayo Clinic. There's an overrepresentation of Irish people there, so we're known locally as the Irish Mafia. And we have a whole group that we do many research studies, and our neuroimmunology lab team also does a lot of work on much of this, and our Mayo Clinic laboratories team who's involved with passing on these test results to the community. And I'd like to thank you all for your attention and for listening today, and please reach out to us in our neuroimmunology lab if you have questions about any of these cases. Thanks so much.